Good evening, respected chairpersons, colleagues, and delegates. So my next three abstracts will be on supportive care. With the first abstract, the three will be targeting mainly on acute radiation dermatitis. The first is the use of Mepitel film, which is silicone-based polyurethane film for the prevention of acute radiation dermatitis in breast cancer. It's a randomized, multi-center, open-label phase 3 trial. So in the background, we know that despite the pivotal role of radiotherapy in averting the recurrence in breast cancer, radiation-induced skin toxicities, namely radiation dermatitis, always remains prevalent. There are symptoms which we have seen with erythema, pigmentation, pruritus, pain, edema, which happen within the initial 2 weeks, peaking at 2 to 4 weeks post-treatment. And it not only poses a risk of treatment interruption, but also long-term toxicities. So how are our supportive care regimens? They are mainly aqueous-based creams and soap with water. However, we have seen that this Mepitel film has presented a promising alternative, which is exhibiting substantial reduction in moist desquamation and improved patient outcomes. The design of the study is as follows. A patient with large breasts after lumpectomy with this specific bra size and cup size, or after mastectomy were eligible with stratification factors of surgery type, dose fractionation, and administration of boost or bolus. So there was a randomization of 2:1 in which we had 266 patients to the Mepitel film arm, among which the received assigned treatment of 251 and completed treatment in 243 patients. The rest were assigned to the standard of care arm. So if we see the results of the study, which are quite promising, because when we have used the film in the arm, we can see here distinct reduction in the moist desquamation as well as grade 2 and grade 3 dermatitis compared to the standard of care, which looks very promising. If we use the particular patient assessment tool also, we can see that the side effects which have been noted in this particular study have shown better benefits with the Mepitel film arm compared to standard of care arm. So the author's conclusion was that as breast cancer is highly prevalent with adjuvant radiation, which is frequently prescribed, this study confirms that this film is beneficial in patients with higher risk of radiation dermatitis, and we recommend the consideration to prevent patients who are at high risk. Now, in the discussion, we can see that clearly this study states that there has been greater efficacy compared to the institutional standard of care, especially for grade 2 to 3 radiation dermatitis among patients, especially with large breast or mastectomy. And these results were benchmarked the previous 2 randomized control trials, which had reported a notable 92% reduction in the dermatitis and 0 moist desquamation. There has been significant radiation dermatitis reductions observed with the Mepitel film, although moist desquamation persisted mainly because of target inclusion of high-risk patients with large breasts and mastectomy, and the decolonization obviously was a strategy to reduce the severity. The discussion or comments, we also see that the analysis showed comparable reductions in other symptoms like tenderness, pain, burning, etc. However, despite the benefits, challenges have emerged, especially when being used in the axillary region, hindrance to daily activities, and also it needs a trained healthcare professional for application. The strengths obviously encompass intentional enrollment of high-risk patients, with stratification based on known risk factors. Limitations included the inability to blind assessments due to the visibility, less number of conventional RT doses, more challenges with the COVID-19 pandemic when the study was done, and also a cost which could be an issue and may influence widespread adoption. So my take-home message is that in the randomized recent trial, the Mepitel film demonstrated superior efficacy of standard care. It is compared favorable to prior trials showing significant radiation dermatitis reduction, but definitely moist desquamation was also an issue. And despite challenges such as certain problems which we have seen, it can be used, and we should be doing larger trials to see its benefit in the future. This is the first abstract. So next abstract is association of Staph aureus colonization with the severity of acute radiation dermatitis. Here we had taken patients with breast or head neck cancer. For the background, acute radiation dermatitis impacts about 95% of cancer patients undergoing radiotherapy, especially as a skin issue within 90 days. It can progress to various stages, leading to worse quality of life and treatment plans. The pathogenesis is unknown. However, Staph aureus is implicated in such cases. It's a pro-inflammatory bacteria which can foster more inflammation and hinder re-epithelialization. So this study explores the association between the nasal Staph aureus colonization before RT and the severity of the radiation dermatitis. So the design was from July 2017 to May 2018. It was a prospective cohort study. Observers were unaware of the colonization status. Enrolled patients of 18 years or older with head, neck, and breast cancer on fractionated radiation therapy with curative intent. Bacterial culture samples were taken via swab from the nair skin in the radiation field and contralateral unradiated skin at 2 points prior to initiation of RT and during final week of radiation. It was graded weekly, and the enrollment was done with subsequent data analysis from September and October 2018. So the results of the study at RT completion, the Staph aureus colonization rate at every tested site was significantly greater among patients who developed grade 2 or higher acute radiation dermatitis compared to patients who developed grade 1 acute radiation dermatitis. Author's conclusion was this cohort study revealed correlation between the baseline nasal Staph aureus colonization and development of grade 2 or higher acute radiation dermatitis in patients with breast or head neck cancer, and they implied that it could be a significant role in the pathogenesis of the ARD. It also implied that Staph aureus colonization was more common in skin with higher grade acute dermatitis post radiotherapy, suggesting that radiation induced disruption enables Staph aureus proliferation and intensifying further inflammation. It also highlights the potential pathogenic role in the radiation dermatitis development, which needs further investigation. Further studies also need to validate in different other diverse cancer cancer types. Considering the success of bacterial decolonization, exploring decolonization prior to pre-radiotherapy as a strategy could reduce further severity of acute radiation dermatitis. Examining the clinical efficacy and cost efficiency of the decolonization prior to radiotherapy has been demonstrated in context like orthopedic surgeon ICU setup. However, we need to use them here to see how better we do with the radiation dermatitis. So my take-home message is the key takeaway from this gathered data is that the significant association between the colonization and development of dermatitis in patients undergoing radiotherapy, it implies a potential pathogenic role of the virus in the radiation dermatitis with skin barrier disruption post-radiotherapy. The findings emphasize the importance of exploring decolonization strategies, which I'll discuss in the next abstract, and further research types in more diverse cancer types is needed. Utility of wound cultures, topical antibiotics, alongside decolonization could help to tailor our interventions further to prevent this dermatitis. The last abstract is related to this abstract, the bacterial decolonization for prevention of radiation dermatitis. So we know there are about 10 million cancer patients undergoing radiation. Yeah? You already know this. Okay. So design of the study where 123 people were assessed for eligibility, among which 80 were randomized, 40 for bacterial decolonization, 40 for standard of care. The results of the study, we could see here that the incidence of moist desquamation was more for the conventional standard of care compared to the bacterial decolonization arm, where we used mupirocin as well as chlorhexidine. The author's conclusion was that the randomized control trial suggested that bacterial decolonization is effective for radiation dermatitis prophylaxis, especially for patients with breast cancer. This trial demonstrated the efficacy of the decolonization regimen. It proved safe and cost-effective in other clinical settings. It recognizing patient preference for cleansers over creams or ointments, personalized treatment plans. There were some limitations with respect to including modification of the primary endpoint, challenges with the questionnaire, and patient expectations, unblinding and institutional standards also regarding corticosteroids could have influenced results. So take-home message was that the study highlights the potential efficacy of bacterial decoronation in reducing the acute radiation dermatitis severity in breast cancer, while acknowledging study limitations, including modifications of primary endpoints, helps, and notably patients with grade 0 acute radiation dermatitis showed better quality of life scores, and further research is needed between this decolonization and topical steroids, which whether use of both could help in better control of the radiation dermatitis. Thank you.